Team's Mark Lovicott revealing the pros and cons of this trend, Mark.
Hey, Eric, specifically we're talking about inducing labor prior to the recommended 39 weeks. Doctors here say it can be dangerous for baby, but for some parents, the convenience factor is the trump card. For Brian and Jessica Yeager,
I get 600.
Life can be extremely hectic. Both work, and they have twin girls. And another baby on the way. Like many parents, they wonder how will they manage childbirth with their schedules.
I guess we both have just assumed our families will help us out, but both of our families live about an hour away. It would be nice to have something to schedule around, to know like, okay, we have this tentative date where we can have people in place where we need them to help with the girls.
The Yeagers are part of a trend, scheduling their delivery, and Jessica hopes it's by C-section.
Right now, the elective deliveries are standing at about 29% of the births in this country, and that's way too high. Back in 1990, they were at 9%.
It's not surprising. Does it make sense? Does it make medical sense? No.
Doctors collectively share worries about any elective delivery before 39 weeks, induction or C-section, with no medical reason for it. In fact, doctors say the practice could lead to serious medical issues for baby, including respiratory and other developmental issues.
Increased risk of requiring intervention by neonatology potentially, and it is just not the recommended practice.
But it still happens.
I think our culture does impact this because we're all checking our BlackBerries. We're all trying to, get as much done as we can in a short period of time. And I think this is sort of a result of that.
Barbara Rudolph works for the Leapfrog Group, a watchdog organization keeping hospitals nationwide in check. She's run the numbers from thousands of hospitals across the U.S.
What we've seen is that there are hospitals that have 0 elective deliveries, and then there are hospitals that have 40–50% of their deliveries being elective deliveries.
Rudolph says Madison hospitals are resisting the trend, but across the country, pre-39-week elective deliveries are up, partially because of pressure from very busy parents.
There's actually competition among hospitals where if patients can't get it at a certain time, they'll shop around to another hospital or another doctor trying to get that to be accomplished.
What number is that?
For Yeager, choosing a scheduled delivery is about convenience, but she says she'd never put her baby in any danger. It's a delicate balance for health and for peace of mind.
It's more of a convenience factor for the family because you don't want any disruptions.
Even the American Congress of OBGYNs has taken a stance on this issue, saying it does not support induction or C-sections before 39 weeks. Still, it happens, and many times it happens through either patient pressure or because of competition among hospitals to get a patient to do business with them. Again, researchers here in Madison say that we are doing well. We're not seeing really many elective deliveries whatsoever take place before 39 weeks.
And so in the Yeager's case, what happened? What's the end result here?
We're happy to actually report that Jessica actually gave birth to a little girl, a healthy baby girl, just a few days ago. Quinn and mom doing well. Turns out they could not talk their dean doctor into doing an elective C-section, and Quinn came naturally on Saturday morning, just a few days after her due date. And Jessica tells us she's actually really happy. She let it come naturally. She was a little anxious when she was going through the process, but she's really happy how it turned out.
Just don't want to take chances if you don't have to.
Not
right?
at all, yeah.
All right. News 3's Mark Lovicott reporting. Mark, thank you.
Feeling it building up.
Because otherwise we'll get used to it.
You'll need about sort of 3 or 4 good mouthfuls before you start to feel the effects.
Back with some almond oil, as this will help her to relax more. Yet another change of position and
But then looking back on it, I've been so relaxed in the whole of the pregnancy, and then you get to, suddenly you start feeling all these pains, and it's such a shock to your system that everyone reacts differently, and I think I just freaked. And what I wish I'd have...
Dural analgesia relieves pain without putting you to sleep. It's usually given early in labour. Click the navigation arrows below the animation screen to play, pause, rewind or fast forward the animation. You will be asked to either lie on your side with your knees drawn up to your tummy and your chin tucked in, or to sit up on the bed and lean forward. Both positions open up the spaces between the bones in your lower back. Your anaesthetist carefully selects a point to inject by feeling for specific bones in the spine. He or she may mark this site with a pen to show where to put the injection. Your anaesthetist will inject a small amount of local anaesthetic into your skin. This completely blocks feeling in the area. When the skin is numb, a larger epidural needle is passed into the epidural space, which is the space outside the membranes that surround the spinal cord. When the needle reaches the correct spot, a fine plastic tube or cannula is inserted through the centre of the needle. The needle is then removed and the tube is left running from the epidural space to the outside. The tube is held in place with adhesive tape. Your anaesthetist uses the tube to inject local anaesthetic or other pain relief medicines directly into the epidural space. Your anaesthetist may attach a pump to the tube so that you can have a top-up when it's needed. It may be possible to control this yourself. This is called patient-controlled analgesia, or PCA. When the need for pain relief has passed, the tube is carefully taken out and the area is covered with a plaster. This is the end of the animation. Click on the animation screen to watch it again.
Come on. She's about to get into the water. The what?
It's a birth plan many moms-to-be are turning to, highlighted in the Jennifer Lopez film, The Backup Plan.
I need to turn over! I need to turn over!
Women choosing water birth will find a much more sophisticated setup at Brookwood Medical Center. It's the first dedicated water birth suite of its kind in the area.
It's another avenue for them to have some pain relief and to allow their bodies to relax during the birthing process and the laboring process.
Dr. Nate Ross has delivered about half a dozen babies by water birth.
We have to use these gloves that go up to your arm or go up to your shoulder, you know, when we're checking people normally, you know, rather than a glove that just goes to the wrist. So yeah, it's a little bit different experience. You have to bend over in the tub. And
Dr. Ross says his practice delivers about 75 babies each month. 1 or 2 of those are delivered by water birth.
There's definitely a trend of more and more women who are interested in having different options when it comes to natural and unmedicated delivery.
Dr. Ross says in the past, both labor and delivery were done in the tub.
A baby has a natural reflex that it will not try to breathe in if it's underwater. It's a natural reflex.
But these days, the tubs are used mostly just for labor. The water temperature is regulated for both the mother and the baby, and the warmth can ease labor pains.
Give me a mirror, I want to see it. No!
There can be concerns about sterilization, but Dr. Ross says they haven't seen that issue at Brookwood. He says it's important to remember water birth is only an option for low-risk births.
If she has some blood pressure problems or is a diabetic or has certain infections, then the water labor and delivery is not a good option for her.
Nevertheless, with the interest in natural lifestyles building, Dr. Ross sees the same trend in water births. He says with the new facility, he believes it'll continue to grow. In Birmingham, Yenu Wadadjo, Focus at 4.
Now, Dr. Ross says that the procedure gained popularity in Europe in the 1970s, but it is new, as you heard, to the Birmingham area. And he also says because the women opting for a water birth are delivering naturally, their labor does tend to be shorter.
Or conflicted. How does an expectant mother prepare? How does she know where to look or what to do? That's where you come in. Childbirth educators clear the noise, providing a mom-to-be with the evidence-based knowledge and tools for a safe and healthy birth. Leading up to birth, a childbirth educator prepares the expectant moms, dads, and families with information and options. Lamaze childbirth educators utilize a wealth of research and evidence to guide families through their pregnancy and birth journeys. As a recognized name with a rich history based on evidence, Lamaze International promotes a natural, safe, and healthy approach to pregnancy, to childbirth, and to the early days as a new parent. Today's modern moms have so much information at their fingertips. Lamaze clearly translates research and evidence that can be easily understood for a healthy birth. Lamaze is built on these 6 healthy birth practices for good outcomes. This strong foundation is what continues to make the organization a leader in childbirth education. As a member of Lamaze, you will be joining respected, skilled childbirth educators who share your passion for impacting the life of an expectant mother. With LCCE after your name, you are declaring your expertise and commitment to evidence-based practice in childbirth education.
The Lamaze Certified Childbirth Educator certification is the only childbirth educator program that has passed rigorous standards set by the National Commission for Certifying Agencies,
which holds one of the highest professional standards of certification. When new and expecting moms are looking for an expert, you will stand apart from your childbirth educator peers when you are Lamaze certified. Lamaze is your ideal partner for current information, support, tools, and education. Lamaze is the only organization with resources specifically for expectant mothers and their families, and resources for you, the childbirth educator. Lamaze is working hand in hand with you to make a difference, one mother at a time. So how can you join thousands of others who are Lamaze certified?
Depending on your experience, there's a pathway to LCCE certification for you.
Inspiration to become certified by Lamaze really began with my own journey to becoming a mom. And I wanted to impart the knowledge and support that women need during this process. It takes so much to be successful and to have a good journey, and I wanted to be part of that.
Being a Lamaze certified childbirth educator gives me a really unique perspective in nursing education. So childbirth educators have always worked really, really hard to make sure that we have a way of reaching out to consumers and a way of reaching out and making things evidence-based but also interactive and fun, and that's really incredibly important as well in nursing education.
Lamaze started me off on my career in birth in a very, very profound way. Lamaze encourages you always to go back to the research, always to understand what is evidence-based, and so that really became the theme of my professional career. It was Lamaze that led me to an advanced practice certification and my life in midwifery.
Want to make a difference one mom at a time? Go online to the Lamaze International website to find your pathway to becoming a Lamaze certified childbirth educator.
To eject the fetus during labor. The birth canal is the lower part of the uterus and the vagina that the fetus passes through as it's born and becomes a baby. The placenta is an organ that attaches the fetus to the wall of the uterus, and its job is to get nutrients from mom's circulation to the baby, to the developing fetus, and in return to get rid of fetal waste products and pass them back through mom so mom can get rid of them in the usual ways that adults excrete waste. The umbilical cord is what attaches the fetus to the placenta, and the amniotic sac is a fluid-filled sac that completely surrounds the fetus in the uterus. Between the back of the vagina and the anus is an area of skin called the perineum. This is important because it's an area that often gets torn during the delivery. If the patient is crowning, it means the baby's coming now. That's bulging of the head through the vagina. You can see the top of the head, even when the mother is not contracting. Bloody show is mucus and blood from the vagina at the beginning of labor, as opposed to breaking water, which is when the amniotic sac fluids sac ruptures and the amniotic fluid comes out from the vagina. And the presenting part is the first part of a delivering fetus that comes out. And you hope that it's the head, because that's the easiest, and you really hope it's not the bottom with the legs folded up, because that's very difficult. While most pregnancies go just fine, there are a number of things that can complicate a pregnancy, and we'll talk about each of these. In a miscarriage, a fetus is delivered before it's able to survive outside of the uterus. The major issue for you is that if there's any parts that are retained, particularly the placenta, the patient can have uncontrolled hemorrhage, and the treatment for that is to contact medical control, start an IV to give IV fluids, and evacuate the patient. If it's a simple, uncomplicated miscarriage, you don't necessarily have to evacuate the patient. A pregnant patient can also suffer from what's called eclampsia, which is a pregnancy-related seizure. We don't actually know for sure why these happen, but they're life-threatening to both the mother and the fetus. Your treatment here is airway, breathing, and circulation control, and contact medical control. The only medication you're going to have that you'll be able to give is diazepam, an anti-seizure medication, and you need to evacuate the patient if that's the case, that they're having an eclamptic seizure during pregnancy. Premature delivery is sort of the flip side of a miscarriage. The fetus is beyond 23 weeks, and so it's theoretically able to survive outside of the uterus, but it's delivered before it completely develops. And this is a real problem. The delivery will be very easy. These are very small fetuses, but if it's under 30 weeks, unless you happen to have a neonatal intensive care unit right next door, chances are pretty good that the fetus is going to end up dying before you can get it to care. Your hope is always that the head delivers first, but sometimes the wrong parts can show up. So the umbilical cord can prolapse. That means it falls out of the vagina before the baby's delivered. And this becomes a problem when the baby's head starts pressing against it, compressing it, and cuts off its own blood supply. So what you need to do is hold the baby's head off the cord and hope that the baby will be urgently evacuated, or that you can deliver the head so that the baby can start breathing on its own, be supported on its own, and not be relying on the umbilical cord. Sometimes a limb, arm or leg, or the buttocks in a breech situation present first. If that's your situation, talk to medical control. They'll have to walk you through the delivery. It becomes much less easy. If you've got a woman who's later in her pregnancy and she starts to have painless vaginal bleeding, you need to be very concerned. This is called placenta previa. The placenta, which is that organ attached to the fetus by the umbilical cord, grows into the wall of the uterus to get nutrients. So there's a huge blood supply, and if it's covering the birth canal, it'll tear from the wall of the uterus and start bleeding, and so the patient can bleed to death. Treatment for this is to contact medical control, establish an IV, and get the patient evacuated as quickly as possible. If the fetus is under a stressful circumstance, its bowels will let loose. The first stool is called meconium, and it's in the amniotic sac, so the fetus is breathing it in and is covered with this, and that's a sign when you see a green stool-covered baby like this that there was fetal distress, and you can expect that the newborn will also be in distress. So your treatment is maintaining the airway, breathing, and circulation of the fetus, and talk to medical control about what you need to do. Alright, now let's switch to labor. Labor is a three-stage affair. The first stage occurs with the first true uterine contraction, and women can have false contractions long before they have their first true contraction. But in the true contractions, their body is gearing up to deliver this baby. And it ends when the cervix, which is the bottommost part of the uterus, essentially, that protrudes into the vagina, completely dilates up to about 10 centimeters so the baby can fit through. The second stage starts at that point and ends when the infant is delivered, and then the third stage starts when the infant's delivered and ends when the placenta is delivered. So you have to remember, is this your first pregnancy? Typically, it takes a lot longer to deliver the first baby than the second, third, or 10th. And so if it's the first, you know you have some time. If it's the 10th, the baby's coming now. Any problems during the pregnancy, that gives you a sense again of the risk to the infant. And do you feel like you need to move your bowels? If they feel like they need to move their bowels, don't let them. That's pressure of the fetus against the rectum, and if they go to the bathroom, there's a reasonable chance they'll deliver the fetus in the toilet, and you don't want to deal with that. And then, do you feel like you need to push? And they may feel like they need to push, but if they're not having frequent or regular contractions, they shouldn't. If they are, then it's probably time. So, if the baby's coming now, the contractions are 2 to 3 minutes apart, you look and you see the head of the baby at the vagina, that's called crowning, or there's severe pressure in the vagina or rectal area, or the mother lets loose with a primal scream, get ready to catch the baby. It's coming now. Hopefully, the mother knows how many there are. That's important to know as well. You want to talk to medical control if you have time. Don't let mom go to the bathroom. Don't tell her to hold her legs together. The baby's coming. And don't boil water. All your equipment should be sterile. Be sure to follow the link on the page in the module at the end of this session to watch a delivery. So what do you need to do? You need to put on your gloves, your mask, your gown, and your eye protection. Mom can either lie on her back with her knees drawn up and the legs spread apart, or she can squat. And if you're in a situation where she can squat, that makes gravity her friend and yours and makes the delivery much easier. You want to create a clean field around the vaginal opening. It doesn't have to be completely sterile, but you want to make sure that there's not dirt or other contaminants. Less for the fetus, which should do okay, and more for mom so that she doesn't get a post-delivery infection. So the head comes out. Put your fingers on the bony parts of the skull. Just the fingertips. Don't push on the face or the soft areas, the fontanelles. You want to be on the bones. And then you're going to very gently let the infant come out. And your job is not to control the direction of the delivery. Your job is to prevent an explosive delivery. If the head's coming out and the amniotic sac is still intact and the woman hasn't broken her water yet, you can use a clamp to puncture the sac and then push it away from the head and mouth as they appear so that the infant can start breathing. Once the head is delivered, put your fingers around the neck and make sure the umbilical cord isn't wrapped around the neck. If it is, you need to slip it off if you can, and if you can't, you need to clamp it and cut it and then unwrap it. Once the head is delivered, support it. You'll have a bulb suction, ideally. You want to suction the mouth 2 or 3 times and suction the nostrils. Try not to hit the back of the mouth. You don't want to cause the baby to gag or vomit. Once the head and the shoulders pass through, the rest of the body slides right out. Support them with both hands. Babies are really slippery. Don't drop the baby. When I did one of my first deliveries as a medical student, the OB attending was standing right behind me. I had the towels in my hand. Baby came out. I dried the baby off, cut the cord. I turned, my back was to the OB, to hand the baby off to the nurses, and I dropped the towel on the floor. Not the baby, but the towel. And the OB nearly passed out. He thought I had dropped the baby. But I didn't. Nonetheless, be very careful. They're really slippery. So now the baby has slid the whole way out. You're supporting the head, the torso, and the feet. Wipe any blood or anything else away from the mouth and nose and receive away from the baby. And then you want to tie or clamp the umbilical cord about 5 centimeters from the baby. And once the cord stops pulsing and there's no more significant blood flow going through it, cut between the clamps or ties, and now you've separated the baby from the placenta. You then need to do what's called an APGAR score. And this is a universally recognized score that describes how a baby's doing at birth, that is 1 minute after delivery, and at 5 minutes. So you've got appearance, which is the color, pulse, which is the heart rate, grimace, which is the irritability, how it responds to stimulation, activity, its muscle tone, is it floppy or nice and strong with active movement, and respiration. So APGAR, appearance, pulse, grimace, activity, respirations. Hopefully if you're using a pre-made kit, it'll have a little APGAR card in to help you score. At that point, if you don't have to resuscitate the infant, you're done with it. Wrap it up, give it to the mama, let her take over, record the information and notify the appropriate authorities. You will need to deliver the placenta. Remember, labor isn't over until the 3rd stage finishes and the placenta is delivered. So you now have a tied off umbilical cord, which is hanging from the vagina. The placenta gets shed from the vaginal wall over the next half an hour or so. So you don't want to yank or tug on the cord, because if you break it above your tie, the mother can bleed to death from it, particularly if it breaks off inside of the body. Once it starts to deliver and you can see it starting to move out, you can apply some very gentle traction to the cord, but you're not yanking or pulling. And if you're going to do that, talk to medical control first. Please watch the video of a delivery and then complete the knowledge review for this session. If you have any questions, please contact your instructor. Thank you.
No problem. I'll start at the beginning. Epidural anesthesia is a very safe and effective way to provide pain relief for women that are in labor. I have a little chart that kind of shows you where the medicine is deposited, but it uses the same principle as when you go to the dentist and get local anesthetic for dental work. We just deposit the local anesthetic near the nerves that innervate the uterus as well as the lower part of the body, so that when women have contractions and deliver the baby, they have good pain control and are able to enjoy the labor process better. As you can see, this is a little complicated, but this is a cross section, and this is the woman's back. The needle gets inserted close to where the nerve roots are in the spine, but not into the spine. And we deposit the local anesthetic so that it will affect the nerve roots and block the transmission of pain. I will show on our lovely model here exactly how the epidural will get placed. Of course, when you do have it placed yourself, the anesthesiologist will have gloves and a gown and a mask, but for demonstrations I'll just use my hands without a mask. The most important thing when getting an epidural is to be positioned correctly, and she's doing a great job here. You kind of have to have bad posture. We ask the women to kind of slump over with their shoulders slumped, as well as their back pressed out. We say either like a mad cat or like a piece of boiled shrimp. And that allows us to place the epidural needle in the correct spot very easily. What you'll feel when the anesthesiologist is placing the epidural is first he'll identify where your hips are. And we kind of will squeeze like this till we find the level of the hips. And we also will go across and find where the midline is. And the place where the epidural will be inserted is at the level of the hips between the vertebrae. And you'll feel the spinous processes. So we'll kind of go down like this till we find the indentation. This one feels like a good spot right there. So you'll feel them with their fingers pressing a little bit, and then at some point they'll use their thumb to make a little indentation. That allows us to know exactly where to go. At this point, we'll have everything ready to go. So we'll take our cleaning solution, which is just usually a betadine alcohol solution. Use a little sponge stick like this to clean off real good. Get it nice and clean. The next point will be to use local anesthetic, just like a lidocaine type medicine. And we use a very small needle for this. And we would basically use the local anesthetic to numb the skin. So we'll make an injection right there. This will sting a little bit, but most women say that insertion of an epidural does not hurt any more than getting the IV started, and certainly a lot less than a contraction. So you'll feel a little burning at the skin that will numb the area. At this point, since the area is prepped and numb, we will use a larger needle. It is a larger needle, but it does not stay in. We use this larger needle to identify where the epidural space is. At this point, as we press down on it, you will feel the pressure of the needle, but it shouldn't be painful, but you'll feel a gritty sensation. That is just us going through the layers to get to the epidural space. Once we're at the epidural space, we will inject local anesthetic to get you comfortable. The local anesthetic is just put in with a syringe. It will feel a little crampy. It's hard to explain that, but that's what women say. They feel a little cramp in their back. That's it's good and bad. We don't want you to hurt, but it also lets us know it's getting placed in the right place. So the local anesthetic will get placed there. Once it's administered, what we'll do is insert a very small and very flexible, very soft piece of plastic. Once we find the epidural space using the needle, we remove the inner cannula and we take the plastic tube and slide it in. And this allows us to place the plastic tube in the epidural space at the appropriate distance. Once it's there, we remove the needle from the skin, like that, and then this is what's left under the skin, about that far, which has holes at the end that allows us to continue to give the medication throughout the rest of your labor and delivery. So once the local's administered and the plastic catheter is placed, we will just tape the rest of the catheter to your back. It'll come up over your shoulder, and we'll hook it up to a machine that will continue to give you medicine throughout the rest of the delivery. Once you've delivered your baby, we just untape the tape and it slides right out. People are always concerned about risks with epidurals, and although there are certainly some serious complications that can happen, most of the time it goes very well without any problems. It usually will not cause any...
It's great you could come here today and see our facility.
Mm-hmm. Tell us a little bit about it.
Well, our facility's new. We've been here for 3 years now, and it's the newest, most up-to-date childbirth center that there is in the Grand Rapids area.
State-of-the-art, very personal, very inviting. You know, it's a really important time when a family is about to have a child to come somewhere that they feel really comfortable.
Sure.
What exactly will they see when a family comes here to have a baby?
Absolutely. Well, what they can experience first is what we call the triage area, which is the area where we bring patients to assess whether they're really in labor or not. Mm-hmm. Once they're determined whether they're in labor, then it's like I said, they get the golden ticket, and then we admit them into the labor and delivery area, which is where we're at right now.
Yeah, and looking around, you've got a lot of wonderful accommodations here, probably the nicest I've seen.
No, it's just absolutely beautiful. It is.
It is. So you've got your TVs, you've got bright big windows, and this is a large room too.
Yes, and all our rooms are the same. All our labor and delivery rooms are centered on the outside here, so they have a beautiful windows and lighting, and again, nice big flat screen TVs, and we want to make it warm and welcoming for not just the patients but their families.
Yes, because this is one of the most memorable moments of someone's
absolutely.
life. After the child is born, where does the mom go after that?
Well, they're brought over to the labor or to the postpartum area, which is on the same floor, which I think is a big benefit that we have here. Again, we try to make it as warm and as inviting for our patients as we can. The postpartum rooms are similar to this, only they're slightly smaller, but again, they're all on the outside of the building, and they're all centered around the nursery, so the moms are never far from their babies.
Wonderful. And I know last year you had more than 1,600 births here at Metro Health Hospital, and that's actually, your numbers are going up.
Yeah, they are, which is amazing. We're the only hospital in Grand Rapids area that had an increase in births over this past year, which, again, compared to what the state of Michigan is with an overall decrease in births statewide, I think we're doing very well.
Wonderful to hear. We're here now with one of the RNs at the Childbirth Center, Nyla Caparis, and I know that you really try to make this a very personal experience.
Yeah, that was one of the goals when we moved here. We wanted high tech, but we also wanted mainly high touch, and we have been doing that. And a few things that make evidence of that is we have state-of-the-art warmer here for the babies, which has all of the bells and whistles that are needed to keep this baby safe. Mm-hmm. We also have all of our gases behind here, so it makes it look like it's really homey and comfortable, but then we can just lift this up and put all the suction and oxygen on as needed. We've also made sure that we set this room up so that the warmer can be moved over so that mom and baby can touch and interact with each other even when we're doing the assessment on the baby.
That's so important.
Another really wonderful thing that we have gone through is our electronic charting system. And what happens then is it links us, first of all, with our physicians. So whatever Dr. Lown, for instance, sees or puts in this chart in the office comes through to us the minute that the patient comes to see us in triage. And that is a real benefit, not only for us to know it immediately, but it helps to keep our patients safe.
Yeah. And this is a place you're going to find a lot of smiling faces. We're here with new mom, Jamie Hebner, and Chase, almost 2 days old. Jamie, what did you think of your experience here?
The experience was wonderful, actually.
came in and took care of her every couple hours, answered any questions that we had. The food was actually wonderful. They had good omelets, good breakfasts. And the other thing too is just the rooms were really nice and large and great for family and friends to come visit. So it was a really good experience.
And she's beautiful.
Thank
Congratulations to you.
Thank you very much.
We are here at the Spartan Stores Family Childbirth Center at Metro Health Hospital. Come and see it. A beautiful place. Wow, wow. I know, that's wonderful. Actually, they were so beautiful, the babies there. The facilities are great. Having gone through the experience not too long ago, a year and a half ago, can really attest that that would be a very comfortable place to be after going through such an amazing thing. Right. You know, that's the biggest thing, pretty much, as you know, moms and dads know, grandparents, to have another member of the family join, you know, the world and your family, and so you really want a comfortable place to have those memorable moments, and it is just beautiful what they have.
It is.
At Metro Health Hospital.
It's an extension of what Metro offers across the board, but really that personal, comfortable feel in the most high-tech, safe environment possible. So again, congratulations to new mom and baby doing well. What an adorable little baby.
Yeah, she was gorgeous. I did get to hold the baby.
Or fast forward the animation. Pregnancy usually lasts about 9 months or 40 weeks and is divided into trimesters. The first trimester is from week 1 until week 12. The second trimester is between weeks 13 and 26, and the third trimester is from week 27 until birth. If you become pregnant, your womb doesn't shed its lining as it normally does at the end of the menstrual cycle, so your periods temporarily stop. This is because the egg, which has been released from one of the ovaries, has been fertilized by a sperm, and you are in the early weeks of pregnancy. Here we show the ovaries, the fallopian tubes, the womb and the vagina. The fertilized egg has already started to divide in the fallopian tube. It will continue to develop and grow in the womb and is called an embryo at this stage. Here we show the embryo in the womb. By week 9, the embryo has developed and is called a fetus. At this point, most of the organs, including the nervous system and heart, are forming. Here we show the fetus in the womb. By the time you are 12 weeks pregnant, your baby is approximately 6 centimetres or 2.5 inches long. At this stage, your baby's neck is uncurling and the limbs are complete. The eyelids are still fused and the ears are forming. Here we show the baby, the umbilical cord, the placenta and the amniotic fluid. The umbilical cord connects the baby to the placenta. This is how your baby gets nutrients and how waste, such as urine, is removed. In the second trimester, your baby's sex organs develop and other organs mature. The baby swallows amniotic fluid and passes it out through its digestive system. The kidneys start to work and pass small amounts of urine. Your baby can now hear and is covered in fine hair called lanugo. Here we show the baby in the second trimester. You may first feel the baby move in the second trimester of pregnancy. The movements become much more vigorous and obvious as the baby gets bigger and stronger. Braxton Hicks, or practice contractions, are painless tightenings of the womb that may start from around 20 weeks of pregnancy. Your baby's lungs mature throughout the third trimester. The baby makes breathing movements even though the lungs don't work properly until birth. The baby grows fine hair and fingernails. The eyes open and close, and teeth may start growing under the gums. Your baby's fat stores also increase in preparation for birth. Braxton Hicks contractions become stronger in the 3rd trimester. At the end of your pregnancy, your baby changes position so it is ready for birth. The baby's head